am audible. Can you all hear me?
Yes, I can.
Yeah, thank you. So we can, resource person, we all can switch on the video also. And since the live streaming is going on, then we can start. There are many participants joining through the YouTube. So we can start. Very good morning to everybody. Welcome all of you all to the panel discussion of iHours 2022, organized by the Faculty of Health Sciences together with the research unit of the Open University of Sri Lanka. The identified topic for the today's panel discussion is public health in crisis strategies to overcome. Public health is a growing field that involves all things contributing to a person's well-being. It's the science of prolonging and improving the quality of life. It includes the studies of aging, disease, mental health, and many more. The world has seen many historical developments in healthcare, including new inventions and systems. Each country has adapted and evolved their own processes for taking care of the citizens in their countries. Since the outbreak of COVID-19 was declared a crisis in 2020, communities around the globe have found themselves in a novel public health crisis. There is currently a health crisis that requires the help of hearing hearts like yours. Therefore, to make you awake in this direction and to have a discussion, we have three eminent resource persons who join us today. Welcome all three of you to have wonderful discussion in this pleasant morning. Welcome, Professor Wajira Disanayake, Senior Professor, Chair, Department of Anatomy, Genetics and Biomedical Informatics, Faculty of Medicine, University of Colombo, Sri Lanka. Then Professor Atula Sumadipala, Emeritus Professor of Psychiatry, School of Medicine, Faculty of Medicine and Health Sciences, Hill University, UK. And together with Professor Chulananda Gunasegara, Consultant, Department of Anesthetics, King's College Hospital, NHS Foundation Trust, UK. Welcome all of you. Thank you all, three of you all being here. Let's move to the panel discussion. Professor Wajira Disanayake, MBBS Colombo, PhD, Nottingham, FNA, SSL, FIA, SHL is the chair and senior professor in the Department of Anatomy, Genetics and Biomedical Informatics and the Dean of the Faculty of Medicine, University of Colombo, Sri Lanka. He is a pioneer and leading researcher in genetics, genomics, biomedical informatics and bioethics in Sri Lanka. Professor Wajira, together with his colleagues, received more than 40 awards. He was the fellow of the National Academy of Sciences of Sri Lanka, a fellow of the International Academy of Health Sciences Informatics, and conferred the Sri Lankan national titular honor of Vidya Jyoti in 2019. Professor Disanayake has held many leadership positions in the field of medicine. He served in various associations and committees, and is also the current president of Sri Lanka Medical Council. With this brief note, we would like to invite Professor Wajira Disanayake to share his views for leading to have a wonderful discussion. Dear Professor Wajira Disanayake, it's over to you.
Thank you very much, Prof. Those kind words of introduction. It is indeed a pleasure for me to be in this panel discussing about the challenges that we face in the current context. It looks as if no one is spared in the current economic, social, and political climates that we are experiencing, not only in our country, but also around the globe. When you look at our country in particular, and if we were to reflect on the challenges that we face, there are several challenges that we have to highlight. Of course, at the core of the current challenges that we face is the fact that we have been unable to kind of adopt and systematically operationalize a sustainable system of financing for our health sector. And as a result of that, we find situations of scarce resources across the board. We always, I think, not only us, but all health systems around the world do not have a perfect situation where they can cater or they can finance all aspects of healthcare. There is rationing at various levels. Even in Sri Lanka, prior to the onset of the current situation, we had rationing. But in today's context, rationing is widespread, so much so that even when you have the wherewithal or the financial means to pay and obtain services, those services are not available. So that's a unique situation that we face, both in the public health sector as well as in the private health sector. And that overcoming that requires innovative thinking and, of course, dealing with factors which are beyond the health sector at a countrywide macroeconomic level. If we focus on the specific issues that come up in the health sector, we find several issues. First, of course, is the issues related to the deployment of healthcare manpower. Not only doctors, but also all categories of healthcare manpower. We find that the so-called brain drain is happening across the board, not only among medical staff or doctors, but also amongst other categories of staff. And that is a challenge which we need to address. We have a situation where I have heard even instances of some of the rural healthcare facilities having had to either close or cut down on their services simply because the doctor or the single doctor serving that place has left the country. And that's a tragedy, given the fact that this country provides free healthcare, provides free education, and all the doctors who are deployed across the country and other healthcare personnel are products of an education system that nurtured them completely through a system of public financing. So we have to address the issue of value of free education and free healthcare. We have to address issues of ethics, the sense of duty and service to those people who supported your entire upbringing and education. And if that is not there, then we have to really rethink the financial models that are operational in the education and health sector of our country. Moving on from there, when it comes to health technologies, we face challenges. The technological, the challenges that we face not only ranges from the medicines, the drugs, but also other forms of technologies, even the simple technologies like catheters to, of course, the high-end technologies. But we have to look at a proper method of systematic evaluation of these technologies, cost-benefit analysis, and ensuring that the most essential, the technologies that would make the difference in terms of life and death, which makes sense in terms of the financial cost of acquiring and delivering them, are made available so that the scarce financial resources are available to and made use of in the best possible way. Otherwise, we will continue to experience further scarcities because the scarce financial resources are not utilized in the optimum way. Moving on from there, we also know that there are effective technologies that were used in the past, which enables Sri Lanka to become one of the most highly effective healthcare systems around the world at a low cost of delivery of those healthcare services that we used in the past to achieve the high health indicators that we have achieved in this country. So we really also ought to look at some of the very effective interventions that we may have used in the past that we may have now replaced with more expensive, newer technologies that in this kind of situation would come in handy and we can use. And that is also another thing that I would like to place on the table, as it were, for us to discuss. Fourthly, there is also the issue of digitalization. We realize today that digitalization brings about cost savings across the board. Digitalization has been adopted across the board in different countries, in different contexts, to bring down costs and increase efficiency in the healthcare systems. There are many examples of that around the world. And there are many examples of that in our country too. In fact, Sri Lanka, because of some of the pioneering efforts that we took in this country, have one of the largest healthcare digital health workforce in the form of doctors with masters in biomedical informatics and masters in health informatics, MD in health informatics. So it is therefore necessary for us to make use of those services, all the manpower that we have produced in this country, to make use of digitalization, deploy and scale up all the hospital information systems and so on, which are now available in some institutions, scale them up, make sure that they are available across the board to all other institutions as well, so that we can bring about efficiency of services, we can bring about expediency of services, as well as we can make services accessible to people who are far away without having to travel long distances, and of course bring about the cost benefits that digitalization actually brings about. to the health system. So in the few minutes that were allocated to me at the beginning, I thought I will put these points on the table for us to discuss. And I'd be happy to elaborate on some of these points that I make further in the discussion and to answer questions that the participants may have. So with those words, I would like to hand back to the chair. Over to you, Prof.
Thank you, Professor Wajira, for sharing the marvelous ideas which can lead for discussion, mainly the issues related to health sectors. It's time for the discussion after completing all the resource person here today with us. Thank you very much. And let's move on to the next resource person, Professor Sumadipala. He is MBBS from University of Colombo, Diploma in Family Medicine and a Doctorate in Family Medicine, Postgraduate Institute of Medicine, MRCH Singh, and PhD from London, and also is a licensed psychiatrist. He was the research associate and later senior lecturer at the Institute of Psychiatry, King's College, London. And he founded the Institute for Research and Development in Sri Lanka and served as the director of the IRD while remaining King's College, London. He was awarded the H.P. Williams Travelling Professorship of the Royal Australian and New Zealand College of Psychiatrists and the Fellowship of the Royal College of Psychiatrists, UK, and received the award Outstanding for the Leadership from NSF, etc., etc. Many more awards. And Professor Sumadipala is also honorary consultant psychiatrist, Midlands Partnership, NHS Foundation Trust, Emeritus Professor of Global Mental Health, King's College, London, and many other positions he was holding. And so with that brief note, would like to have Professor Hattula who are leading to have a interesting discussion further. Thank you.
Thank you so much for that kind words, those kind words. I'm just trying to get my slides on board. Okay, thank you very much for giving me this opportunity to talk about the public health crisis, strategies to overcome. Now, outline of my talk, actually, I'll take you through very briefly what is public health, what is a crisis, what is a public health crisis, and then discuss public health crisis in the context of COVID-19, then take you through some of the lessons we learned during the last 2 to 3 years, and come up with a conceptual framework for a Center for Disease Control and Prevention, which we have been discussing since COVID, and give you some reflections on changes and challenges and barriers, not only my personal, because we have a large group working together, so they are just beyond personal thoughts, and suggest some strategies to overcome. Now, what is public health? We all know public health is the science of protecting and improving the health of the people and their communities. This work is achieved by promoting healthy lifestyles, researching disease and injury prevention, and detecting, preventing, and responding to infectious diseases. Overall, public health is concerned with protecting the health of entire populations. These populations can be as small as local neighborhood or as big as an entire country or region in the world. Now, as the WHO defines, public health refers to all organized measures to prevent disease, promote health, and prolong life among populations as a whole. Its activities aim to provide conditions in which people can be healthy and focus on entire populations, not on individual patient or disease. That's the difference between public health and individual health. The public health is also concerned with the total system and not only eradication of disease or a particular disease. Now, what is a crisis? Crisis, a time of intense difficulty or danger, or time when a difficult or important decisions must be made. The turning point of a disease when an important challenge has taken place, indicating either recovery or death. So we faced all these, fitting a crisis, particularly during COVID and also post-COVID under the current socio-political and economic crisis. Now, what is a public health crisis? It's very interesting. When you go through this, some would say racism is a public health crisis. That is to say that attitudes, beliefs also contribute from the mental health point of view, creating a crisis. It's abandoned. You know, there are a lot of campaigns, people talking about racism as a crisis. Then also antibiotic resistance, which is a looming public health crisis. Protecting health, health manpower, loss of health manpower, as Professor Disanayake very correctly said. So why is a public health crisis is also a political problem? We all know we are facing a global crisis, global financial crisis, and it's a political crisis as well. So in a way, when we talk about a public health crisis, it is to do with socio-political, economic crisis in the world. And we have to remember this is a global crisis. Some people think it's only, you know, we Sri Lankans are facing it. We have to, unless we put it in the global context, we are going to miss everything. And the strategies, the implementation, arguments, all would be based on a very narrow pathway. Now, it's clearly COVID-19 was designed for a public health crisis because it was, when it's a pandemic, it was not just an epidemic. And there was a double burden. Generally, we know communicable diseases come as crisis, come as epidemics and pandemics. We also have non-communicable diseases, but the most crucial thing with COVID-19 was there was comorbidity and the effect of COVID-19 on the medical status of non-communicable disease. Patients present the direct effect of outbreak on patients with medical illnesses. It's in this study, the effect of COVID-19 on communicable disease, case study in 6 countries, this study established beyond any doubt that pre-existing non-communicable disease as a risk factor for becoming infected with a severe form of COVID-19, leading to deaths in most cases. It also revealed that the effect of COVID-19 on non-communicable disease outcomes and complications, including mental health. So it was a double burden. In this backdrop, you know, we had to act fast. We have excellent health system. You all know excellent public health system, infrastructure, some healthcare institution within every 2 square kilometers. In spite of that, prompt action had to be taken. So this Center for National Coordination and Prevention of COVID-19 was established, and the Triforces were involved. It's not uncommon globally for the Triforces to be included in such pandemics. In fact, CDC Atlanta is a uniform service as well, as we know. So I was fortunate to work there for 2 years, voluntarily though, daily basis, spending hours and hours. And we also had extensive consultations with PDs, RDs, hospital directors. It was not just an operation based on a center in Colombo. And there was, at one point, an independent expert panel was appointed to review the COVID operations, which was led by Dr. Palitha Abeykoon, who was special envoy to COVID-19, WHO CRO region. with leading experts like, you can see here, Dr. Ananda Vijay Vikrama, Professor Buddhika Gampodi, Professor Veerasinghe, Dr. Nilika Malavige. So we came up with this interim report as well. In that, what we identified was what was needed to strengthen the existing system, also learning from the existing gap by critically reviewing them. As I told you, with wide consultations, we held so many consultations over weeks and weeks. While the overall strategy was extremely crucial, the need was to strengthen the country level coordination, planning and monitoring, information handling, data management and sharing, testing strategy, including establishing public health laboratory system, because we didn't have, if not for Professor Nilika Malavige's existing laboratory system in Jayawardenepura, most of you would know that things would have been very different. Then risk communication, community engagement, vaccinations. We know that Sri Lanka had an excellent vaccine record, even ahead of WHO targets when it comes to those days triple vaccination. However, the difference this time was it has to be given within a very short period of time. So there were a lot of challenges which has to be faced. The Center for National Operations, we also had to deal with hospitalization. At one point, there were no hospital beds. So we established under Professor Indika Karunatilaka's leadership, 1904, which we provided services. We phoned people, spend hours and hours triaging. All that brought some experience to think about. We had continuous discussions, and we also use printed and electronic media heavily because communication is a key. Communication at different levels was needed. So with that, it was also very clear the unique link between education and health. What the role between health and the impact of all that gap. So with all this, we continued discussing how to face the challenges, realizing the gaps. So we felt that excellent epidemiology unit couldn't handle certain things due to many deficiencies. I'll talk about them. So therefore, we proposed and still continue to propose work on this. This is just a draft, helicopter view of what we think. Center for Disease Control and Prevention, basically upgrading the epidemiology unit under DG or DPHS, which didn't have adequate amount of health and statistics. Data was there, but there was no capacity to analyze the data within a very short period of time by the good, excellent manpower was there, but the time challenging factors were affected. Conducting research was not possible in a short-term basis. There was also other issues, not data sharing. And we have a health promotion bureau, but the communication gaps were very clear. Vaccination, as I told you, had to be given in a very sort of fast manner. Public health laboratory system, there were gaps. Relevant university department and academics were there, but the incorporating them in the whole process was limited, but we had to do it through the center. National Institute of Occupational Health, it does a huge amount of work, particularly with free trade zone people who came from abroad. So there was a clear role for them as well. Then Disaster Management Center, National Operations Center, as I told you, Sri Lanka Medical Association, the apex body which provide the advocacy. And Colombo Municipal Council is also a separate unit. And there was Presidential Task Force for Economy Revival and Power Eradication. So we thought, bringing in all these under the leadership of Center for Disease Control would make a difference, like CDC Atlanta. Now then we proposed this and got feedback, which we always do. So this is one of the young consultant community physician. He said the concept is good. There are certain aspects to learn from the developed world. However, his main critique was the root causes of current challenges public health in our context is different, and mainly a problem of not having good governance and ethical conduct, because there were issues, even within the same ministry, officials were not prepared to work with each other. They had hierarchical authority, sometimes, even it was like ownership issues. So in his opinion, he said establishment of an institute like CDC may not be feasible in the backdrop of current economic crisis. The proposed structure also seems to support direct political involvement, which may hinder the evidence-based decision making. And he said, I think the current need is to address the issues scientifically, which being having people who can commit for common benefit. And he questioned what are the strategies we have. How empowered are we to practice science while challenging personal interest of politicians and sometimes the professionals? In the proposed organogram, he says almost all the arms are already there, which is true in our system, but there is no professional approach for proper coordination because lack of professionalism. His serious criticism was the root causes are the lack of trust, honesty, credibility, professionalism, leadership skills, management skills, life skills, monitoring and evaluation skills. He said, unless we address these key issues by developing a system and building capacity, there wouldn't be any progress. He said, my thoughts may be negative, yet I believe that we need to address root causes scientifically and to build the system while strengthening the legal system. I'm going to stop very soon. Then we also had another response from a experienced, committed public health consultant lady. She said, still seems the structure has a lot of bureaucracy. When there are a lot of directors, assistant directors, sometimes who think they own it, it creates many barriers due to individual personal characteristics. So can't be more futuristic. Nowadays, the private sector IT developers are using concept called Scrum, which has become very popular in rapidly reaching targets, bypassing the red tapes. It's based on small teams who work based on short-term targets. And she said she's not an expert on it, but she feels that we need to change this working culture. When we introduce powerful positions, the time of the worker implementer is spent on to overcome the personality issues of that particular person. Wrong people at wrong places was identified as a strong barrier for progress. So she said, let's be futuristic. Otherwise, whatever the best model we develop, everything will depend on the person who sits in that top chair, because policies can be made after consultations, but when it comes to delivering, implementation bottlenecks are to do with attitudes. So a public health professor, of course, said it's good, it has to be done, and having a Center for Disease Control would be good, but he came up with this challenge. He said, when appointing people through open advertisement, which is done in CDC, will not be possible in the hierarchical structure because there are owners. The influence of unions will also be a counterpart. So considering all this, what are the strategies to overcome? My last 3 slides. We need a culture shift, definitely, beyond any doubt. That culture shift is about changing the ethos and the targets. A bad attitude is like a flat tire. You can't go anywhere without changing it. Attitude changes everything. So therefore, need a culture shift, change internally, change externally. Changing the systems alone or establishing new system is not going to work as long as attitudes are not changed. Professor Vajra Disanayake mentioned about the attitude of free education, how to pay back for the public funding. All that has to be taken into account, and we need to reflect on what had happened very seriously under the current political, socio-economic crisis. This culture shift demand change beyond politicians. Take it from me. Government officials need to take the responsibility and change, because we know the hierarchical positions. Professionals and professional organizations, cross-board, you name it, there are barriers to progress. There are hindrances, and that has to change. These ownership issues, as Vajra very correctly said, ethical conduct of professionals has to be upheld. And not only that, public too has a responsibility. It's like dangerous crossing pedestrians in Sri Lanka. You can't demand from the next vehicle driver to do it unless you drive and respect the pedestrian crossing. So it's time to put our house in order. Unless we do that, we can't move. So finally, I think all this can be achieved through this socio-political or only through education reforms, because emotional intelligence is important. Just intelligence is not going to work. I know it's a long shot, but that is the only shot. If we are serious about public health, we need to have an integrated thinking. Everything has to change. And the bottom line, changing the attitudes will only come through serious educational reforms. I would like to end my talk by saying, Gamburu muhuda hasatane tani minisa jaganunnata. Petty ownerships has to be defeated. Collective responsibility has to be upheld. We are using public money, public funding, knowledge, everything. We are yet another group of people who have been nominated to work for the people's benefit. Unless we come through that, pointing fingers only at politicians is not going to uphold public health in Sri Lanka. Thank you very much.
Okay, thank you, Professor Atula, for enlightening us with the ideas on public crisis and challenges on. This all we lead for a discussion. So in a few minutes, right? Thank you very much. And let's move on to the Professor Chulananda Gunasegala. So he obtained Bachelor of Medicine, Bachelor of Surgery, University of Peradeniya, Doctor of Medicine in Anesthesiology, and Postgraduate Institute of Medicine, Colombo. He served as a Doctor, Royal College Physician, London. And he was the former dean. Researcher achievements include research in areas psychouterine reflex in childhood and hypertension. Also, he Master of Royal College Pediatrics and Child Health London, Royal College Physician, London Fellow, College Anesthesiology of Royal College Surgeons, Ireland. And also is a research fellow registrar, Institute Child Health London, Pumalga, South Africa, senior registrar, Institute Child Health London, Pumalga, South Africa, and so many positions he was holding. With that very brief note, we would like to invite Professor Chulananda Gunasegala to share his valuable ideas with this forum. Thank you. This is over to you, Professor Chulananda.
Good afternoon, everybody. Kalavani, thank you for that introduction, which is a bit overwhelming. I am privileged to be part of your discussion today, and I was even more privileged to listen to two other speakers and learn a lot during the process. So the title of the theme today is Public Health in Crisis and Strategies to Overcome. And this is an excellent, valuable, timely theme. And my public health knowledge is very little. I have had some old experience as a pediatrician some time ago, but I'm a novice. But using the wide kind of clinical experience that I have, I've made some effort to address this. Fortunately, this actually tallies with what was said by Professors Wajira and Atula. So I do not think that we can overcome the crisis, but hence I have changes to health crisis mitigation strategy. So we will minimize the effects of the crisis in a clinical setting. This is from our own papers in Ireland, women and children the most affected by Lanka's economic crisis. Now, of these speakers, now you will know that we all had undergraduate medical training at the same era, same curriculum. But today, I cannot even dream of doing what they are doing. And I presume they would say the same about me as well. So you can see how focused we are when we get senior. We all know we hit an economic crisis and we were declared as bankrupt on 12th April this year. So what are the effects of recessions on health? Now, this is not something that we have to learn now. There are other countries that has faced similar situations in the past. So let's look at that a little bit in this context. So you have a huge problem here, and we are trying to pull it forward. We got to move it really fast and so on. Yes, that is true. We are really busy. But some people might suggest little improvements to it, like changing the square wheels to a round wheel, which might take better. Now, that's what we want. We don't want to reinvent things, but instead perfect the situation with what we have at the moment. So what we know in a recession is that the economy struggles. We know that. People lose work. We know that. The companies lose profit and they close. And we've already seen that in Sri Lanka. And the country's overall economic output declines. We see that the value of your salary drops. We see that a loaf of bread is like 300 to 400 rupees. Threats to health are multiple. Now, look at this. Stress and lack of health care increase cardiovascular morbidities. This is known because you get more stress because of the economic crisis and lack of health care because of the reasons that Professor Wajira already mentioned. Then malnutrition affects generations of children. That's very important to understand that we don't want a future generation that's been malnourished and affected. Then the communicable diseases increase due to rising cost of amenities. That's number one, as Professor Atul mentions, and the weakening of preventive and control measures. This is also, Professor Wajira mentions that people are not there in rural centers to carry out the health needs. So look at Brazil, 2012 to 2017 economic recession, effect on adults, it increased mortality rate by 8%. So the higher end employment there accounted for so many deaths. Then all-cause mortality increased among Black or mixed race in that country. Now, this is important for us to understand. There was no significant association was identified between unemployment and all-cause mortality for white Brazilian women, adolescents, or old and retired individuals. So there are factors that might in the same group that might affect different peoples differently. So the Brazilian recession contributed to increases in mortality through health and social protection measures expenditure seemed to mitigate detrimental health effects, especially among vulnerable populations. So if you do the health and social protection expenditure in vulnerable population, then you can mitigate the effect. So learning point from there is effects are not uniform. There are huge variations, and this can be regional, gender-based, and age, and so on. So that's lesson number one from that. So the job loss affects the stability of families and individuals. Health and well-being can get drastically impacted by the loss of a job. That is obvious. While some who lose their job may use the time for growth and exploration, as it's happening already in Sri Lanka, others suffer with depression, alcoholism, and denial. Now, this is the area for Professor Atul to talk about in the discussion. Now, that's about the children. Now, in Spain, 2005 to 2013, understanding the impact of economic crisis on child health, found that unemployment rates increased during that time to 25%. The percentage of children living under the poverty line and income inequalities increased by 15 to 20%. So children get most affected during this time. Severe material deprivation rate has worsened, primary education get affected. That's another aspect. The number of families attending NGOs increased. Now in Sri Lanka, lots of NGOs operating. An impact on general health, mental health, and use of healthcare services was found in vulnerable groups. Now, this is particularly important because the people who tend to get affected are the more likely ones who will not visit healthcare services. So you have to proactively go and find them among the vulnerable groups. Now, in relation to investment in social protection and public policies for children, specifically is that as a part of austerity measure, that means all that as a part of austerity measure, you increase investment in public policy for children was taken by Spanish government, and that was beneficial. So despite the impact on social determinants, an impact on child health was detected only in specific vulnerable groups. So it's not a uniform thing. The findings suggest the need to urgently protect vulnerable groups of children from the impact of austerity. So the learning point there is there are vulnerable children, not everyone, they need to be identified proactively. So we have to have a method of finding them proactively. Now, here's a systematic review about economic crisis in 2008 on child health. Now, this is something that we are already seeing in Sri Lanka, high food prices, reduced diversity in the food. So that means if it's cost in the morning, cost in the evening, cost in the night, and cost tomorrow as well. Nutritional quality drops as a result of it, and quantity of the diet also drops. This impacts the most vulnerable groups, not everyone. The poorest populations from urban areas are the most vulnerable to food insecurity and malnutrition. The evidence to date associates the crisis with violence against children. Now, this is another aspect that people have to look at. In the adult population, mental health problems, family stress, violence, and suicides increase in the time of crisis. Now, here's another aspect that Professor Atula can talk about during the discussion. So the vulnerable groups, who are these vulnerable groups? They have to be proactively found and identified. That's the most important thing that I'm saying at the moment. The women are among the most vulnerable people to economic shocks. Women are often the first to lose their jobs. Now, amongst the economics group, most vulnerable groups are the agricultural labor households in the rural areas and the casual labor households in the urban areas. So again, look for problems in those families. So the others are children, pregnant women, elderly people, malnourished people, prisoners, migrants and refugees, people who use drugs and who are immunocompromised are generally the vulnerable groups, but there are variations regionally and so on. So just be looked upon. So the conclusion is that the most studies suggest that the economic crisis poses a serious threat to children's health, disproportionately affects the most vulnerable groups, and monitor the child health effects of the recession and to inform appropriate public health policy problems. So in addition, do not forget this, the great recession on mental health, substance use, and violence in families. That's again a psychiatry area, and I'm not an expert at all on this, but you have an expert on the panel. Now here, a scholar from us, Dr. Rohan Pathiagoda, wins Lenin Model, which is Nobel kind of prize for naturalists, but he was speaking just a couple of months ago in the SJP convocation. And I extracted a few extractions from him. It takes 4 minutes to play it, but that has got huge relevance for us to understand what is needed. So I play it first, and then.
And I think, especially in this year that we have seen, most of you have discovered for the first time, probably in your lives, a certain political awareness. You became aware that something is deeply wrong with our country, and many of you peacefully protested to change that. Today, Sri Lanka is in a crisis. It is in a crisis because people didn't have something.
Sorry, I think I can't play it for some reason. Let me try again. Sorry, there's a problem with this thing's slides. I'll put it on again. Just give me a second. Give me a second. I'll get the slides on again. Sorry about that. Just. Okay. Let's see now.
And I think, especially in this year that we have seen, most of you have discovered for the first time, probably in your lives, a certain political awareness. You became aware that something is deeply wrong with our country, and many of you peacefully protested to change that. Today, Sri Lanka is in a crisis. It is in a crisis because people didn't have something that every one of you has a mother who has lots of. Our mothers are people, I think you will all realize, who are rich in a thing called common sense. If you think about it, our primary problem started with the inflation we are seeing in our economy as a result of the central bank, the governor of the central bank 2 years ago, going on to print 2.3 trillion rupees in paper money, money that was not supported by growth in the economy. That always leads to inflation. Common sense says that if you look at the other countries in the world, every country that has done that has had a financial collapse, an economic collapse. The governor of our central bank, highly qualified, professional, academic, PhD from the University of Oxford, denied that there was a link between money supply and inflation, didn't use common sense. Your mother would not have done that. We saw what happened with organic agriculture. Overnight, the government decided to change agricultural policy. The agricultural expertise that has been taught by universities for the last 50 years, scientific modern agriculture, was put aside, and we decided to take agriculture back by 100 years to the 19th century. Common sense said, you should look at any other countries in the world. There are more than almost 200 countries in the world. Has any country successfully done this? No. So then common sense says, it's unlikely that you will be the first successful one. That's what your mother would have said, no problem. Even people who are highly competent and qualified, when they don't use common sense, can make serious mistakes. We made that with the Dhammika Paniya. We had the government telling us that the Dhammika Paniya is a cure for COVID. If it is a cure for COVID, how come that Pfizer and Moderna and AstraZeneca sold $100 billion worth of COVID vaccines last year? Sri Lanka should have got that $100 billion for successfully selling the Dhammika Paniya, but we didn't. Common sense said they were wrong. So when people reject science, when people reject the learning that you have received at university, they can make huge mistakes. Science, as you have learned, is about testing hypotheses. It's about evaluating evidence. It's not about listening to the most qualified person. Our economy is in ruins. The government has stopped recruiting new staff. The private sector is shrinking rapidly. The private sector has lost more than 500,000 jobs this year alone. Things are bad, friends, because coming out of this kind of economic crisis is a very slow, long, tedious process. It's not going to be as bad, however, as some people say. We have an intellectual foundation to our society. So yes, the coming years are going to be tough. They're going to be tough for all of us, but especially for you, because you are going to be out there looking for jobs. Our predicament is because of corrupt, crooked, ignorant politicians. They have been the curse of our country since independence. But I don't doubt for one moment that you have the skills, you have the intelligence, and you have the knowledge. This is your moment. This is your time. I hope you will be equal to this challenge.
So I 100% agree with the contents that I extracted from that speech, and I showed it to you. And we have to learn from the mistakes, as Professor Atula said. And we have to walk the talk. That means we have to make it work, as Professor Vajira said. Now, so learn from our mistakes, use common sense when we are approaching this, give authority and leadership to people who know how by track record. And the listeners, we have a foundation of education in Sri Lanka, which is very different to other countries, and use it so that we can get out of this trouble. Titles and qualifications alone are insufficient to guarantee benefit, and take regional differences into account, and use local talent supported with education and evidence. Now, this is another thing that we should focus on. But we have two additional problems in Sri Lanka. The first one, the resources are limited: money, personnel, equipment, as Professor Vajira said at the very first talk. Then the second problem we have is we should also think about lukewarm government, because the politicians for the people is kind of not existence, is more for politicians at the moment. So the extra government help is unlikely to come through, because they have 8,000 politicians in this small country of 20 million people, plus the 225, plus the 1 million surplus police, mainly political stooges, to be support. So this is another problem. So, but leave it to a side, don't think about it. Let's see how to address it as the health issue. Seek support from expatriates, local personnel, aid agencies, etc., and even United Nations. Now, we need good data. Now, here, environment, all official statistics on elephants bogus. We don't want bogus data. That was one problem earlier on. Collect true data proactively, regionally, and work together, because we have to identify the vulnerable people from the vulnerable groups. So that's important. Now, since 1971, we have resorted to violence as a resolution to our problems. Now, we should learn that, denounce violence by all means, because there are no winners. We all are the losers if we resort to that. So the take-home message now, prevention is better than cure. Proactively here, because that's important, because passively you may not detect these people who are affected. Identify what factors are contributing to public health crisis using our current own continuous data. That needs continuing true data and evidence. Understand that requirements in different regions may differ. Say the North and the East, the Hill Country and the South and the West will be different in their requirements. Get regional leaders on the job to do the job. MOHs, PHIs who have been on the job, on the vaccinations, etc. Find local solutions, not parachuted individuals dictating from air-conditioned rooms. Use available resources to address the most critical factors contributing to the public health decline. Ships are not coming at the moment. There's no money to import things. Educational institutions like the Open University should get directly involved to educate people as to how to get these things sorted out. The most cost-effective way to progress is to educate staff at the grassroots level and resource direction to apply evidence-based rectifying tools, including advice regionally. And preventive measures for public health decline should not include the intermediaries who have often exploited the available funds with corrupt politicians. So that's another thing to somehow safeguard your resources. So I will stop there for the now and open for discussion. Thank you very much for the opportunity. And as Professor Vajira and Atula said, we need to walk the talk. There's no point just talking. We need to walk the talk. Otherwise, we will not find the solutions on the ground. Thank you very much.
Thank you, Professor Chulananta, for the thoughtful ideas. So highlighting the public crisis together with the economic crisis and the strategies impact. And this is another point that for the discussion now. So without taking much time, that the resource panel, eminent resource persons that you all are here to have a wonderful discussion. You all touch in various aspects, financial crisis, policies, mental health, economic crisis, and politics, and many things. And then those are the points now that you all have together. So before getting open for the participants, so so you are the valuable resources. So then you all three can start the discussion. To start the discussion, just I thought of I can just raise you all touched that the diseases and mental health and so much that so just I would like to, because as a normal person or general public in their mind, so-called the infectious diseases, to take you all to little bit the points that you have discussed, to go to little bit in depth. So the infectious disease, that is the persistent threat to the public. And when it comes to that term, then that the public, that's a root cause for the public health crisis currently. It is for everybody, so the individuals, that is, they all go through that. And also the question is that infectious diseases, when it is at a chronic level, so it may lead to for the death and thing. But the problem is now the highlighted point in worldwide, the antibiotic resistance. So the Professor Atula, you all have also pointed out. So the question is, so why, like when it comes to the antibiotic resistance, so together with this infectious diseases, so what may be the impact and how it can have an impact on our day-to-day activity and the treatment, therapeutic treatment and things like that. So just to start the discussion, just put this point, then the resource person, you both, all three of you are invited to move forward with the discussion, what the topic on the public health crisis and the strategies to overcome. This is all to you for the panel members.
I think this is a question to Chula. Chula, you will be the best to answer that, I guess.
Well, I don't know. I mean, I'm not a public health official, as you say, but I've been a pediatrician for a while,
Yeah.
so I understand a little bit about public health because I work with them. As I said, I think you need to get the people who have been on public health for a long time, like the MOHs, the PHIs in the front line, so that they can suggest ideas, they can say what to be done, because there'll be lots of regional differences. Say our focus at this particular time is not trying to change the government or something else, because none of that is going to happen. What we need to do is we need to see how we can address the issues at local level so that we don't have, say, at least malnourished children or malnourished pregnant people and so on. Because the people who come for even vaccination now, Professor Atula mentioned about vaccination programs. Now, people in this kind of situation, they don't come for it. That's what is there. They will not attend the healthcare services. So even if it's available, availability will be a problem, as well as uptake will be a problem. So again, communicable diseases, there is a problem. Antibiotic resistance, I'm not the expert to talk about that at all. And I think the collectiveness, togetherness, as you mentioned, is very important. And the framework, you cannot have this kind of stratagem and anesthesis. So you cannot have a plan when you start the anesthetic, because things change during the surgeries, and and things have to change. And here it's the same as well. You cannot have a plan at the beginning of the year and say, this is what we are going to do until the end of the year, because the situation changed, the resources change, the people change, and so on. And also, I very much took into account what you said, Wajira, about the financial models that need change in relation to education, which is not a topic here, but that's something very important that we have to think about. Thank you.
Can I come in, Chula? Yeah, thank you for that comment. Although I'm a psychiatrist and a family physician, I have got a public health background as well. So when we talk about public health, let's not, get compartmentalized into just talking about infectious disease or individual illnesses and all that. And I think the global trend now is, since COVID, communicable, non-communicable disease double burden. Now, going back to my experience during the COVID, now we know we have excellent public health system in Sri Lanka. No one can doubt about preventive system, even compared to Europe, Chula, where you and I used to work, you still work. The public health people in UK actually was praising the public health in Sri Lanka. And even the curative services, we are not that backward. Immunization, we had achieved all that. But when it came to COVID, the challenge was delivering services in a situation where it was unprecedented background. I think as there was the question posed by Dr. Dinesh, as said, the whole process which I witnessed was about decision making. The extensive consultations we had with grassroots epidemiologists, over 100 people, they said, don't come back to us if you cannot deliver, because what they said, good policies are there, human resources is there, but implementation bottlenecks were the issues. Yes, there is a resource issue right now due to economic crisis, that's true, but an excellent system, why is it falling? Yes, as Wajira said, some people are leaving, but still we can deliver. But as Dinesh very correctly said, and as I highlighted, I think what needs to change, as Chula said, walk the talk. The top people, whether they are politicians or government officials, experts, you mentioned about the central bank person, they shouldn't think that they know everything. One of the greatest weaknesses, Chula, not knowing what you don't know. And the ownership issues. You said expatriates using, Chula, you and I know how difficult for expatriate to come back to Sri Lanka and get settled. You are rejected. There's professional envy. And they do everything to try and block you. So those petty ownership, we are in a crisis as a nation. You very correctly said, we need to shed our differences. Think about the country first. If the country doesn't survive, the health system doesn't survive, we can't deliver anything. So let people leave. That's the human trend. Even from states, if there's space to go to moon, people will go. But you can retain them, expatriate for nation development. And in the crisis, what to me the most important thing, whether it's public health, political, economic, people to get together and work together, shedding petty personal differences, respecting knowledge, commitment of people who really want to serve the nation, Chula. Unless we do that, this is going to go downhill. But I think it's a turning point. People, enemies of progress, whether they are politicians, professionals, government officials, will not be able to survive within the next 5 years in this country. I will vouch for that. Thank you.
All right, thank you, Professor Atula. I think the chair can decide, but I want to just read a comment because I think it's important that we engage the audience. And there is a comment that has come through, you will have seen on the chat. There's this person, this doctor is saying that, thank you for this golden opportunity for me. There is a problem with the decision making in the health sector for recent past. Now we are paying for that bad decision making. By now also, there is no clear mandate in Ministry of Health to overcome the effects of this economic crisis. Is there any steps that the forefront health workers can do? That's the question. And I think that should be the focus. That is what I said, walk the talk. We need these people in the forefront. So I think it's good that the people in the audience speak up and talk. That's one of the weaknesses in Sri Lanka. And then I was just listening to your keynote address by Professor Arjuna. He also more or less said the same thing in his keynote address just an hour ago. So why not we get the audience to talk about their ideas?
Yeah, now the time for the audience, the participants. So there are 47 participants here, and through YouTube, there may be many watching this panel discussion. So that's the resource person are here, the wonderful time, and the people can raise many aspects. They can clarify and can have a fruitful discussion. So all are invited.
While the audience thinks about questions to ask, Chula, just to respond and also to respond to that comment on the chat. Yeah, I think it's very important for all of us to think through what our individual roles are, because everyone can make a difference in their workplace, whoever they are. And it's very important to have that kind of intellectual dialogue. What is my role and how can I play it more effectively? How can I be a more effective person in the role that I'm playing? So that is unfortunately something that is not happening. And so I guess it is up to those in leadership positions in various institutions, whatever level they are, to start that dialogue with their peers, their employees, and so on. So, for example, you see, if we look at our institutions, we find that everybody wants more of the resources, but with very little understanding of what those resources cost. And there's very little dialogue by institutional heads on the economic cost of what is being provided and delivered, and what's the value that we give society through that the spending that we have. So the cost benefit of what we are doing and so on, understanding that is so very important. Like, for example, if we look at the question that the chair posed to us about antibiotic resistance, well, if we prescribe antibiotics indiscriminately, and then as a result of that, if the cheaper drugs are resistant to the cheaper drugs are not effective, then we'd have to go for the more expensive newer drugs. So therefore, it is important dealing with that kind of very simple issue of preventing indiscriminate use of antibiotics, and what can we do for that? What are the measures that we can take for that at our own institutional level, and so on. So these are dialogues, discussions that people have to, have at their own institutional level, not at the level of the ministry. I mean, you can take the decisions at the ministry, but what can how does that get implemented at the level of an institution? So that has to happen at the local leadership level. So therefore, I think eventually each one of us have to ask that question: what is my role? How do I pay it more effectively? I think that therein lies the answer to overcoming these challenges. And to overcome the challenges, we'll really, I think, also would have to make individual sacrifices. And that is a definite item on the agenda. And unfortunately, people are not actually willing to make those sacrifices, and their solution is to, say, okay, we leave the country, and then we go down further down the precipice. So that's what I'm seeing happening, day to day across the board, everywhere, in all our institutions. So it's a bit of a sad situation at the moment.
You're right, Vajira. I think we should give chance for the participants. I think somebody's raised their hand. Host has to deal with it. Asri has raised the hand.
Yeah, I think I can. Shall I talk, or I think it's okay? So I'm Dr. Asiri. I'm a public health professional working in the Ministry of Health. So as the guest speakers clearly said, there should be a drastic change within the system to address this problem. But what we see as people who are working in the health ministry, that nobody's initiating this discussion. And also there are so many bureaucratic issues that even if somebody wants to do a change or is trying to do a change, there are so many red tapes that you have to pass and to get the approval. So we have all these financial regulations and all ways of doing things. So, but since we are in a crisis, is there a way that we can sort of pressurize these bureaucratic teams to come up with certain I wouldn't say shortcuts, but new ways of doing things, and rather than the old traditional ways that we are doing still in this digital era, while knowing that the cost of papers are so high, still we have to print letters and pass every copies to each and everyone. So how can we change this? As Professor Vajira very correctly said, we are trying to digitalize, but when somebody is trying to initiate something, there are so many other pressures from other people and who are not in agreement with such decisions. So there are a lot of frustration within the system as well. So how can we overcome that is one of my one question. And the second one, recently now we all see, as Professor Chula said, that at this moment, we should focus on targeted interventions rather than going for all these universal distribution of food and water and everything. But recently, one of the public health professional teams in NGOs, they said identifying the target groups also involves a cost. So it's better to go for universal rather than going for targeted interventions. But I find it very difficult to understand that, because providing, I mean, even unnecessary people are getting all these items free of charge. So how can we overcome that also is my second question, to do this identification of targeted groups at a low cost and do this targeted intervention rather than focusing on this universal distribution of everything. Thank you.
I can try and answer the first one, being a institutional head here, heading actually at the moment 3 institutions. I can tell you, I don't see any of the administrative regulations and financial regulations as barrier for us to do work expeditiously. It is the reluctance on part of those in administrative positions to take decisions. That, it's the reluctance on part of those in positions to take decisions. I can, I'll tell that 3 times if you want. It is everything is place. The national, the legislation is there for us to do everything digitally. They are not being used. E-procurements are there. Everything, all the, we have the best legislation in place. We have even now Data Protection Act properly in place. It is up to those in leadership positions to take decisions and implement them. That is why I said none of the decisions, even if the decisions are taken in the Secretary Health Office, they will not get implemented if an institutional head does not implement them. So that is what we are doing in universities. We have, I mean, at the moment, almost more than 90% digital, I can say. So it is up to individuals to take the decisions and move forward. And my thoughts on your second question is, yes, I mean, the days of one size fits all interventions are gone. We need to make decisions based on data. Data should guide us in decision making. And if you look at the Ministry of Health, there are big data sets now which are available, which can be used very effectively for decision making. And I don't think they are being used. For example, if you look at the IMMR system, which is gathering all the morbidity and mortality data of all the institutions in the country, there is granular level data that is available for you to make decisions on deployment of resources, where that data should be, where the resources should be deployed. So it's up to those people at various levels to make use of these data sets and ensure that they are using this data for decision making and for targeted interventions, not for one size fits all interventions. There are lots of other systems as well which are generating a lot of decision making data. And the next thing is, of course, the silo mentality, where you are not willing to share your data for decision making. And that is one of the tragic things. I think Atula mentioned that in a coded way when he talked. That was the tragic thing that we found in the response to COVID. People were not willing to share data. People wanted to develop their own systems when there was already data available through other means, and we just had to piggyback on systems. And we could have had, so for example, the DHIS2 data set that was developed by our own Sri Lankan doctors working in the Ministry of Health was implemented in 50 other countries and not in Sri Lanka. And it was eventually another system again developed by them, which was implemented. But these are what we really need to change is mindsets of people. They have to change their mindset. They have to become collaborative, and they have to take leadership and make decisions in the places that they are in. And that is my answer to the questions that were raised. Thank you very much.
Yeah, I think Dr. Azari.
Right. Yes, you go ahead.
Yeah, okay. So I think, Dr. Azari, I think you're very brave to talk about that and then tell us about the bureaucratic problems. Now, I just take a couple of minutes just to bring some examples from the past. So bureaucracy is always a problem when you want to change status quo. So status quos don't change just because you have a good idea or people think it's a good idea. If you go back in history in Sri Lanka, when Postgraduate Institute of Medicine was formed in 1976, that has to be closed down because of the protests. And then the first students who attended exams from the PGIM in 1980s some of them had to face death threats. Now, that's the kind of way the PGIM was established in Sri Lanka. And at that time, there was a director called Dr. Cabral, and then he must have faced lots of problems when it's been established. And in that context, I later found out he was a friend of Dr. Gray. Dr. Gray is not the Gray's Anatomy person, but the person who wrote books in anesthesia from Liverpool. And later I found out that they were being friends. Then Dr. Gray has also had similar opposition when he was trying to change anesthetic practices. And then the survival game was educate the juniors, educate the juniors, educate the juniors. And that's what Wajira said just now, saying change the mindset. So that's the one that actually eventually helps you to survive yourself and change the practices or change the status quo. Now, for myself, as Atula said, I have faced all these in my own personal experience. I was rejected as expatriate when I was back in Sri Lanka after postgraduate education in 1991. Then after that, status quo changed, like introducing degree programs for nurses. Then I faced the same problem, huge protest, introducing transplant program nationally, same problem, I faced the same thing, introducing critical care as a degree, I faced the same issues. So don't give up. Do the education, say the values, and then keep going on and on and on. And here today, one of the most important thing is targeted intervention, as everyone is saying, and focus on that, keep on that, and contact us also if necessary. Otherwise, we will carry on doing that. I'm actually doing some work at the moment, but we can achieve it. Thank you very much.
Chula, just to add to what you said, you mentioned about Dr. Cabral and PGIM. My father was the founding senior registrar academic. He faced the same changes, but I wouldn't go into that. Asiri, thank you very much for raising this issue. And I totally agree with Wajira. It's the people who need to take responsibility and do the change. But being a psychiatrist, Asiri, I know there's always resistance to change. And that is very difficult, and it needs a lot of patience, working with others, gathering the momentum and breaking the conformity of wrongdoing. And as you all said, as everybody says, it's the time, change of attitudes, as what I said, let's change the flat tires. If we get together and do it, that's the only way forward as professionals. Now we need to unite as professionals and look at the big picture and go ahead. That's the only way to do it. As Wajira said, there was huge resistance of sharing data. Data belongs to people. It's not any personal legacy of any official or a professional. So we need to break that. We need not only to talk about ethics, we need to walk the talk about professional ethics. Let's do that. And in that, we need to get the support of the public as well. Thank you.
Yeah, listening to you all, yeah, we have to break to the walk. So how it is possible, like we all throughout the period, so we were so many forums, we were discussing many panels, many talk, and people are talking that maybe several forums, but still that how, when it comes to implementation, how it will be possible. Like here also today also is a wonderful forum that people, these thoughts to everybody's mind, that's have to do something, and we had to, the decision we have to make, and we have to share the data and things like that. But when it comes to the real practice, the implementation, so there may be barriers, as you all pointed out, many things. So how it may be possible, but when you think about other 10 years time, right, how we can walk through that to break these barriers, and how we can go ahead, just to would like to listen from you all.
So as I said, and in fact, I delivered the CWW Kannangara oration on the 13th of October. And that's why I say, it will take time. Don't expect quick fix. The change will come only through serious educational reforms in Sri Lanka. So as academics, as researchers, as citizens, as patriotic professionals, that's where we should invest.
Okay, we would like to listen from the participants more and more questions. We have other half an hour time, so there is one chat. Okay.
Anybody
So,
talking there? No. Okay.
Yeah.
Shall I talk a
Yeah,
little
yeah.
bit? Because I think
Yeah,
you are
sure.
asking how to
Yeah.
overcome. Yeah. How to
Professor
overcome
Chula.
problems. Yeah, I can give you
Yeah,
an
yeah.
example. So when in 2006, 2005, when we were trying to establish degree programs in Sri Lanka, there was no except the Open University, which had a short degree program for nurses, there were no qualifying people who will qualify as lecturers to teach in the universities. Now you can imagine the problem that 170 students being admitted to learn 5 degree programs, including nursing, medical laboratory science, and so on, and not having a single lecturer to do any of this in the education forum. So this is the kind of challenge we had. Now you can understand how difficult it must have been. So you have to find strategies how to do it, and particularly in the presence of opposition at that time from the GMO, a huge opposition. So they were preventing all the lecturers coming in, even the medics. So at that particular time, how can we overcome that? Now, if you take a Toyota car that everybody thinks, oh, it's wonderful, it's not an individual person who develops it. It's many people who do their professional bit better so that the Toyota comes out because of that. So likewise, the education programs at that time that was there for all these courses were broken down into very small modules that can be done by scientists, the art lecturers, the engineers, the dental people, and so on. So the education program now was set by using small modules that can be done by other people and not the same professionals. So the nurses were taught by many other people with small modules so that the nurses emerge in the program. You see what I mean? So you have to find a strategy to overcome a problem that is not overcomeable in the superficial way or the traditional way. So that's why we have a very educated foundation, and all those listeners in this audience are very, very intelligent, and also they have founding thoughts, but they have to bring it out and then tell you, and we have to net those ideas as well and then carry on with that. And education is the key. And as Atula says, education reform means that get this education down to the ground level, to the root level, and keep doing that, and then you will get there. So don't take status quo as a barrier. It's not a barrier.
Yeah, thank you, Professor Cholan. So it's really, really a thoughtful message from everybody of you all. So some more time, another 10 minutes or more, if there is any questions from the participants.
Not only questions, any comments would also be valuable. I think one of the problems, in fact, we are right now witnessing, there are 50 people, but only one person spoke. People should start speaking out. They shouldn't be worried about expressing their opinions. You may be the minority at the beginning. So please do comment.
Yeah, it's true.
So can I talk? I'm Dinesh.
Of course,
sure,
yes.
Doctor.
Yes, can I talk now?
Yes.
Sorry, sir. Sorry,
Yeah,
sir.
sure,
Sorry for
Dr.
disturbing.
Dinesh.
So now I'm working in the medical supplies field. Now we are experiencing the lack of resources or the deteriorating of medical supplies. So what is your view of initializing a national criteria of allocating health resources for the persons? I mean, it should be gender basis or the basis of age or something like that, because now we are lacking of resources or lack of medical supplies. Are we experiencing that?
Yes, definitely. We need proper, health technology assessment and a recommendation. So that is something lacking. And that is why, as a result of that, there's a free for all kind of system. There is, so we need to bring about some rationality. So, for example, I think Atula and Chula will tell about UK, you have NICE, which will come up with the guidelines, and you can't just, anybody cannot be ordering any drug. But here in our country, it's every consultant can do whatever they want and order the best drug, with no reference to what is effective and what brings the cost benefit and so on. So these are drastic changes that we need to bring about. And what I wanted to say earlier was we need champions for change at all levels. So in institutional level, whatever directorate level, there should be champions for change everywhere. One person may be able to do it, but he would struggle. But we need champions for change everywhere. And if there are champions for change, I think we can change this country.
Okay, thank you, sir.
Chula, Asiri had asked a question. I think you will be able to answer that.
Can you suggest any examples of public-private partnerships that had worked in economic crisis?
Yes.
This Sri Lanka, these people have, this is a political word, public and private. Say nothing can be done free because everything has a cost. So it comes to at the delivery point as free, but it is cost. So if it's a free, who is supporting that? It's us supporting it. Public money, the taxes you pay, the tax you pay when you import something, whatever. All that is the money that gives you saying it's free. So public and private partnership, there's a difference. So if it's public money, then if it loses, then everyone has to pay for it because if there's no benefit. Private is that if they loses, it's only the private people will have to pay for it. So, but the impression that has been given to us is that the public, the private people always earn a lot of money from public, but that's not quite the case. So you have to identify which should be public, which should be private, because say, for example, bus service, okay, at night. Now, private bus owners will not want to travel at 10 o'clock every day when there's only one passenger. But so that kind of thing has to be a public service. Whereas if it's a very common thing, which is competitive and can be bought at cheap price, then that can be the private partnership that you can get at a competitive level. So the public service gets it at a very competitive price. And if they lose it, then it's not a public cost. So this is a very interesting topic, that how to get public-private partnership works. And even in these Western countries, the public service, for example, the National Health Service is free. Yeah, everybody wants is free, yes. But then there are lots of private partnerships that's been taken in. I'll tell you one example in the COVID crisis. I was an anesthetist. So in the COVID crisis, there was not possible to do all the urgent and also kind of non-urgent operations. So I was involved in neurosurgery. So what did the government do? They took up all the operating theaters that are in private hospitals in London. And all the patients that we looked and assessed for surgery were sent to those operating theaters in private hospitals as national health patients. And then so basically borrowed the facility, used the staff from the National Health Service to carry out the public duty of providing the public health services. So these kind of models you have to use from time to time to achieve it. I see this kind of model being proposed in Sri Lanka in a different way, but this is not the time to apply that kind of a model, because that means because somebody is trying to take some kind of profit from this. So that is not the way it should be used. So that's the kind of partnership you have to see. So first of all, you have to identify what is a public service that we need. Two is where you can get competitive private partnership so that the service can be bought by public money at no loss to the public. That's what matters. Okay, that's
Yes,
a different subject.
Okay, one more question here. Just to clarify, as mentioned by Professor Attila, how the cultural shift can be done. Could you please
Yeah.
elaborate the concept?
Yeah, culture shift. It takes time, number one. So you have to give you an example. When the helmets came to Sri Lanka first, for people working in the development sector, they used to have the helmet outside and work. But it took time. So awareness raising is one. To give you a classic example, if you go by the Professor Solomon Nash principles of conformity, he did interesting. If you go to YouTube, you can find he did many interesting research pieces to show it. He got a group of people, 9, out of which 8 were his own stooges. Only 1 person came from outside. He drew 7 lines. The 7th one was clearly short. Then ask his stooges from 1 to number 8 whether these lines are same or different. And his stooges said they are same. And 80% of people who came from outside as the 9th person also said all the lines are same. But then he challenged and asked, how can be it's short? But then this person said, when the majority say it's the same, how can I say that? That's one example. If you go to the YouTube again, there is a nice clip where there's a reception. He plants 5 of his stooges there. When a bell rings, all 5 gets up and sit down, gets up and sit down. Then he gets 1 to leave when another one come from outside. That person also follows this other 4 people. When the bell rings, come, sit down and stand up. Then actually, eventually, all his 5 people left and outside people were seated. They were still going on standing and seating. So that's the conformity principle. But if you get 10 people to sit there who will not stand, that process ends. So that's an example. Having said that, it's a very difficult, challenging one. It takes time. It takes time. And as the message said, keep on punching on the same spot. Same thing, voicing it. It will take some time. And as I said before, culture shift is not going to happen overnight, but it's very important, attitude change, win over few people, get them to voice the same thing, and eventually things will change. And as I said again, that culture shift can only, in my opinion, be done through serious educational reforms, starting from grade 1, so that we create a new generation over the next 20 years. That's all what I can say. I don't know, Chula, you may have things to add to that.
Yeah, I agree. I agree very much with what you're saying. This mindset change, culture shift has to come from education. So it has to come with a very lower level, grassroots level kind of education in the level that they can understand. And also give examples why we need to change. So what you're saying is absolutely right. Yeah. So that's what I was trying to do. I'm trying to do at very basic level. Yeah.
So, yeah, any more questions, comments, clarifications from?
Dr. Kalewani, may I
Yes.
ask more question?
Sure, Dr. Dean, Faculty of Health Sciences, Dr.
Yeah,
Sunil.
I'm Sunil, Dean, Faculty of Health Sciences. So this is more relevant for the education that Professor Atul also just conclude, and also Professor Shula also is a remarkable person for allied when considering about the allied health science education. So I have a concern now. Allied health sciences still limited to the conventional university in a very small scale, and so the nursing is the second, largest workforce belongs to that profession. So now they are thinking to develop their own university education. I think it's again a political move, and they want to develop their own university under the. It's not clear whether it's under the Ministry of Health or either under the higher education. So anyway, then the conventional university system also thinking that whether if they develop a separate school-like university, then what happened to the conventional university system, which have already that programs. So I think the public health is, in a way, we should have a quality healthcare workforce as well. So with that move, what is your idea how that allied health education, which direction the allied health education need to move forward? Maybe Professor Chula
This is
can.
not a new problem, Sunil, as you say. I have been trying to introduce postgraduate education with people who are in public health, in allied health education. And there is a little bit of fear among them. That's one problem. They don't want to come out because they might get targeted. That's what they think. But I don't think that will be the case. That's your own perception. So the allied health education is hugely in demand in the world. And if we had allied health graduates at this particular time, they can go anywhere in the world at very high salaries, and that will be beneficial to our own country. Like, for example, India has done. They've got expatriates everywhere doing various jobs. Philippines has done. They have got expatriates everywhere in, say, particularly nursing. The nurses from Philippines are head chased to give jobs all over the world. So this is possible. This is not possible. You can do education. And when people are talking about this university systems, that is where the problems comes in, because you don't need a university system in the structure that is available in Sri Lanka at the moment to start another degree program, start a postgraduate program. The structure there is enough. When you say university, you want a university, you can't do it because that has to come from the UGC approval, and then the money has to come from the non-allied, non-academic staff, then all the printers, the officers, the chairs, and everything else. You don't need any of this. You can do the program with nothing, like what I did. So when we started, there was nothing. And then we started, yes, no building, nothing at all when we started in 2006. But then we could acquire a hall that was being used for Gaje mostly, because there's a hall that was completely occupied by university students. So when I looked at the registration, there were only 8 people who were actually paying the rent as a whole resident, and all the others were Gajes. So I said, transfer the 8 who are paying to other hotels or hostels, and then it was free. So the others couldn't claim it. So there are lots of things that you can explore and then apply. And I don't think you need a university or separate university to do anything, because the current university system is good enough to do any program within your structure.
Thank you, Rosjula. I also thought, I mean, rather than developing a separate school, why don't we expand the existing system? But I think there's again the politics is behind that, and they want to develop their own separate university, so-called university. I don't know whether it's come under Ministry of Health or, but I heard that they have a separate Parliament Act also passed about that. I'm not much aware about the current situation.
Thank you. There is one more question in the chat box as a suggestion for the health sector, HR and financial crisis. I think we have to focus on how to maximize the efficiency of available resource utilization, task shifting, altering working hours, and taking extra work with incentives, appreciation, utilize night hours for using machines, analyze resource utilization and redistribute if underutilized. Some suggestions. The resource persons here, if you all can address this question.
Yeah, I mean, Asir is absolutely right. I think what she is saying, we don't have to think more. We have to think differently. That's exactly what Asir is suggesting. That's a good suggestion. But the thing is, how can it come down? Unfortunately, because the hierarchical system in our country, it has to be top down. So if it is health, we have to convince the DG, which is not impossible. I think it's worth, requesting him to consider these things. We should try, but as a strategy, you're absolutely right, Asiri. Chula may have something to say about it.
Oh, yeah. You can convince anybody. There's no problem with that. I've done that many times in Sri Lanka. But the only thing is you have to give good evidence, good data, and good suggestion to say why we need it. That's what we need to do. I mean, you'll be surprised that when emergency medicine was proposed, and this was not in the what is called healthcare minute, because otherwise it doesn't become a specialty. In 2011, I did a presentation why emergency medicine was required with some pictures and Sinhala subtitles in my slides. I had about 10, 12 slides to Maithripala Sirisena. He was the health minister at the time, and the secretary was there. And I think DG was there, and only 3 or 4 people. And 10 minutes presentation, at the end of it, the minister and the director said, let's do it. We need emergency medicine as a specialty in Sri Lanka. So it happened. So that is how you can convince the people. Go there with data, not personal connections. Go with data, tell the need, why it is, and so on. And then you can use the current, even the top-down system to get it done. So you can, there's absolutely no problem with that.
Yeah. Now, I think that time, 2 hours time that we all have discussed, if there is any 1 or 2 questions, quick questions, we can take it up. Sorry to announce, Professor Vajira Dissanayake also left because he had some other work at 1:30 and he left. Professor Chulana, Professor Chulana and Professor Atula was they are here. So if any question, 1 or 2 question quickly, we can take it up. So since it is silent means okay. From Dr. Shriyani, at present, usually healthcare professionals are going for foreign employment. How it will affect for public health in the country? So Dr. Shriyani from head nursing, the questions are posed here. So
obviously,
Yeah.
they're leaving, and that will affect the human resource. And I think the solution is what Asiri said. So make a case for it. Need data, amount of people leaving, and then suggest to the government to do it in a facilitated manner, because they can't go by force. There has to be some legislation as well. And it's a controlled release of professionals has to be done. And it's again planning. And whether we like it or not, we will have to deal with people who remain in Sri Lanka.
I think this is a huge topic. I think it's not that simple as that. So can he or she write to me and then we can discuss that separately? I don't think it's a simple issue like that.
No.
I think human rights and the human wishes comes into play. It's not really can be forced down.
Dr. Kalaivani, can I talk?
yeah,
Yes.
sure, Dr. Andika, go ahead.
Okay. So, Chula sir, thank you for having the Chula sir and Professor Sumatipala. Thank you for having this fruitful discussion. And as my first dean in my undergraduate degree, we know how difficult it was for you. And now at the moment, I'm also following the same path with some other aspects. So the difficulties and challenges. Thank you for giving that strength to us. So my question again lies with Dr. Shriyani. So now everyone is leaving. So that is a like huge problem, like our qualified staff will not return, so everything will be a, huge challenge for us. So in like in the mental aspects, we also feel somewhat frustrated, and all other things come up with this crisis. So sir and Professor Sumati Pala, both as the resource persons, do you believe that this will be having, like, even we change our attitudes, even we help the others to change their attitudes, will it have a proper end in our near future?
Can I answer first, Randika? Yeah. Randika, you got
Yes,
a
sir.
platform that was not available, say, 15 years ago, called digital platform, and Vajra is an expert on that. And digital platform will make it very easy for you to adapt and recruit more people. And the question is, because I know you cannot do skill training with a digital platform. You can do lectures. What we do in lectures can be do in digital platform. There can be a little bit of interactive digital platform to, so what I'm saying is use the new technology and new resources you have and recruit more people. And controlling the people's outflow is a government job, it's a political job, it's not ours. But I don't believe that you can keeping people by force is going to improve service. I think keeping people by willingness is the one that's going to improve the service. So that's what I think. So increase and recruit more, and also use the UGC guidelines in relation to the quality of education programs, and that also keep it well updated to the current needs, and there'll be no demand for your courses. So you can do that, and then I'm happy to help wherever I can. Thank you.
Okay, thank you very much for all of you all. Now this time for coming to the wind up the sessions. So on behalf of the organizing committee, I would like to thank the resource person, Professor Vajra Disanayake, Senior Professor, Department of Anatomy, Genetics and Biomedical Informatics, Faculty of Medicine, University of Colombo, Sri Lanka, Professor Atula Sumadipala, Emeritus Professor of Psychiatry and School of Medicine, Faculty of Medicine and Health Sciences, Hill University, UK, Professor Chulananda Gunasegara, Consultant, Department of Anesthetics, King's College Hospital, NHS Foundation Trust, UK. Really, it is very wonderful, that interesting, informative sessions. So not only to address the public crisis and the strategies, more than that, I believe definitely the audience and all the participants, they might have some courage. So by looking you all, the talk that you all that put the path and the strong ideas. So that will lead to the academics, here scientists and all other listeners. So that this message, the take-home message, that will take into everybody's mind. So as you all said, it cannot be done overnight or in a very short while. So that all leads to, it may take time, but you all put the ideas he placed in a right way and the motivation to the people. So definitely this will be a message for all the public and all the community here that you all shared. So, and I would take the opportunity to thank all of you all. So you all spend with your very busy schedule, and you all join not only from Sri Lanka, but also from UK, and so spending time with the timing and all. So that so it's a wonderful time that shared with you all with the Open University. This is on behalf of the Faculty of Health Sciences and the research unit of the Open University and the Open University together. So I'd like to take to thank you very much, and we had a very wonderful time with you all. Thank you, all the participants and whoever joined through the Zoom and the YouTube. So thank you all. Have a pleasant day. Thank you.
Thank you very much.